All right, for those of you who don't know, Mike's one of our fellows this year and is going to speak to us about MIS and trauma. So, Mike, without further ado, why don't you go ahead and
Awesome.
educate us?
Yes. So I was a little curious about this talk when I was first assigned it, but it ended up being a lot of fun. I learned a lot. I think you guys are going to enjoy it. It is a big topic, so I'll try to stay on track. It's a topic that's pretty easy to get sidetracked with lots of different areas that you could kind of take this, but we'll try to stick with MIS and that in context of trauma. Brief overview. Uh, what is MIS? So first, starting with the definition, it's basically a collection of surgical techniques, strategies, and instrumentation. It's designed to achieve the same goals as more open traditional surgery, but through a smaller incision, theoretically providing less damage to the muscle and soft tissue at the time of surgery. And it also frequently uses intramuscular planes through different dilation methods to accomplish that, somewhat of a narrow corridor. It was originally described to treat degenerative lumbar conditions, but now it's frequently used for more damage control orthopedics, which we'll talk about throughout the talk, and with respect to polytrauma patients. Um, and those applications continue to expand. It's mostly in the thoracolumbar spine, so that's what we're going to focus on today, although with time, more cervical applications are coming out as well. Um, Common themes as I was preparing this talk, MIS does not mean, kind of you abandon your normal surgical goals. So, uh, in the context of this conversation, MIS has to include accomplishing normal surgical goals, maintaining the principles of spine surgery, specifically neurologic decompression, stabilization, and deformity correction, as well as adequate intraoperative imaging, which is a pretty big risk factor for where this can kind of go wrong. From a historical perspective, a couple kind of major things led to where we are today. The operative microscope, the percutaneous pedicle screw, which is probably the largest application of this technique, lateral transpsoas surgery, as well as kyphoplasty, and then some of the more traditional surgeries being brought with a minimally invasive component to them. So where are we? Why do we care about MIS, and specifically in the context of thoracolumbar trauma? 160,000 spine fractures a year. More than 50% of those are in the thoracolumbar spine. Typically a bimodal age distribution, either younger, healthier patients with higher energy mechanisms or elderly patients with lower energy mechanisms. Unfortunately, about 25% of these do involve some component of the spinal cord, so either compression or frank spinal cord injury, obviously in the thoracic spine. And those can frequently require stabilization and surgical fixation. These patients also typically have additional injuries outside of the thoracolumbar spine, so either a non-continuous injury in the cervical spine or additional head or extremity trauma. And you can get trauma to the thorax and abdomen as well. These patients are sick, is another thing to keep in mind. That's also part of where this application can show its strength. Even if they weren't sick, once you've had a trauma, the inflammation and everything increases. You have an infection rate that can be about 0.7% for anterior procedures, 3.1% for posterior procedures, but I've seen it as high as 10% in the literature. Traditional surgery via posterior standard midline approach has iatrogenic muscle denervation, increased intramuscular pressure. So think of like a iatrogenic compartment syndrome, specifically from retractors usually. And that can cause tissue ischemia and then subsequent revascularization injury as well. This can lead to paraspinal muscle atrophy and decreased endurance. So how can we use this? I think there's four pretty major ways that this can be applied. The biggest one, in my opinion, is pedicle screws with or without fracture reduction. So acute traumas using ligamentotaxis principles in order to provide reduction and stabilization of the fractured vertebral body. This is most commonly a wedge or a burst fracture, and there are plenty of company-specific implants and systems designed to accomplish this. Also, kyphoplasty or vertebroplasty, so cement augmentation for compression fractures. This is another major application in terms of providing pain relief, which we'll talk about. Endoscopy and then MIS lateral approach or a mini open approach, specifically with corpectomy and anterior decompression. And we'll get into that as well. Can't really have a conversation about thoracolumbar trauma and MIS surgery without TLIX. So this is a classification that we can use to kind of categorize fractures. It looks at a variety of things. It looks at the morphology of the injury, so either compression, translation, and rotation, or distraction, which you can see examples of there. Then it looks at the integrity of the PLC and neurologic status, and you can kind of use those things in order to combine. You can combine all those factors in order to create guidelines as far as which approach to use given neurologic status and whether or not the PLC is intact. Like any other classification, it's kind of useless unless it's reliable. So this is a study looking at the reliability of the TLIX classification. It had really good intra and pretty good interrelated reliability. They looked at 362 cases and retrospectively with TLIX greater than 5, and they found that 98% of them did receive surgery. And you can see in the bottom, typically 4 could go either way depending on surgeon discretion. But 5 is generally recommended for operative fixation, and 3 or less is generally non-operative. So greater than 5, they had 98% that did receive surgery, and then less than 3, there were 90% of the patients that did not receive surgery. So indicates that it may be a little more reliable for 5 or higher scores. And you can see the sensitivity and specificity on the bottom there, as well as the positive and negative predictive values, all pretty good, which is what you would expect in a classification system. These are just a couple examples real quick of how you can apply it. So on the left, flexion burst fracture, neurologically intact, loss of integrity of the PLC, so a total of 7 points. And then flexion distraction injury on the right, T12, L1, Asia A, with a definite injury to the PLC for a total of 9. Both of those would be recommended to receive surgery. And then one final one here, burst fracture, incomplete spinal cord injury with compression and the burst, and then the PLC injury, you have a total of 8 points. Additional classification is the AO spine thoracolumbar injury classification. As far as I could find, based on the couple meta-analysis that were done, this classification is more inter-observer reliability and is frequently used as more descriptive as compared to the TLIX, which is used typically for therapeutic decision making. So actually, how are you going to treat the patient? I think this has a little bit more application when it comes to research and kind of more specific description of fracture morphology, which is definitely has its roles and can help in communication and accurate relaying information for the research side. It also considers the fracture morphology, neurologic status, and case-specific modifiers. Okay, so with that background, kind of getting into what we're here for. So when I looked up MIS versus open surgery, I promise these are 2 pictures that popped up, which is kind of funny because I think this is how the discussion goes sometimes. It's not really comparing apples to apples. You know, you have a small, probably like discectomy on the left, and then a big deformity reconstruction on the right, in both of those respectively. So we're going to try and compare apples to apples in this talk as best we can, and go from there. So the big thing with MIS is to understand different doesn't always mean good. So what is the benefit of this kind of new technique over the last, 10, 15 years as more research starts to come out about it? The benefits are pretty clear. I think we all know smaller skin incisions, less invasive means less tissue trauma, reduced surgical trauma. Typically, the larger posterior midline incisions can have a lot of trauma associated with that, which we'll get into shortly. You can have less blood loss, meaning less transfusions and possibly less infection rates secondary to that. And you can also have preservation of the anatomic structures, faster recovery time and rehabilitation, as well as with less pain. OR time depends on who you ask. I think at the end of the day, it comes down to who's more comfortable. That being said, a lot of people view MIS as more technically difficult. You're not seeing full breadth of the anatomy, so it's somewhat easy to get lost in terms of where you are. And that's why intraoperative fluoroscopy and other navigation techniques are very important. Can have a steep learning curve, which we'll examine, poor visualization, risk of inadequate decompression or fixation, usually secondary to poor visualization, as well as increased radiation exposure. So instead of kind of visually seeing directly where you are, you're relying on a lot of fluoroscopy-based techniques or sometimes CT-assisted navigation or robotic surgery in order to kind of accomplish your goals and locate yourself. So probably the most important application of MIS, I think, is percutaneous pedicle screw placement. especially with respect to trauma. With anything you're doing, you need to first make sure it's safe before you even consider if it's better or worse, because if it's not safe, you're not going to do it. So this is a study looking at the CT accuracy of percutaneous versus open pedicle screws. There's a total of 16,000 or 1,600 screws, excuse me, 223 patients, about 50-50, 880 percutaneous versus 700 freehand. Overall, they found their pedicle breach rate was a little bit lower in percutaneous placement. Their vertebral body breach rate was lower as well. And then their facet breach rate was a little higher actually in percutaneous, though that wasn't statistically significant. I think that makes sense, as you do it percutaneously, you're trying to avoid the facet, and sometimes that's a little harder to see on fluoroscopy as compared to intraoperatively with direct visualization. The average magnitude of the breach was also less on the open, which to me indicates that once you are lost, if you continue and you're not really sure exactly where you are, you're not confident in your location, it's easier to propagate a minor error into a more major error. So a larger magnitude of breach with the percutaneous technique. And then that's just going over on the right, some of those images, what their classification was as far as degree of cortical violation for grade 0, 1, 2, and 3, and then their facet perforation as well. So if it's safe, can we use technology to help us? And of course, you have to give an AI plug in there, even though it's not really related, but I feel like it's not an appropriate talk without it. So this is a study looking at the accuracy of robotic assisted or robotic guided versus freehand techniques, 170 patients over 8 years, about even robot versus freehand or fluoro assisted. Clinically acceptable, which was their grade A or B, was higher in the robotic group. So 93 versus 89%. There's a lot of other studies on this, similar results. Some of the studies had higher accuracy rates, about like 99 versus 96%. It all just depends on what you define as clinically acceptable. And this finding was only significant for the lumbar screws as compared to the thoracic screws, which to me was a little bit interesting. I figured that the thoracic screws would be harder with the smaller pedicles. But they seem to think that it was secondary to a statistical bias, because there were significantly more lumbosacral patients as compared to the thoracic, which you can see there's 380 essentially lumbosacral screws compared to 60. So I can't see. Is it safe? Obviously, if you're using percutaneous techniques, you're not directly visualizing. That's never something you want to hear if David and I are in the room alone, which you can see there. So if you can't see and you're using fluoro-based techniques, obviously you can look at your AP and lateral views to triangulate orthogonal views where you are, but you can also stimulate the actual screws. So lots of studies talk about this as far as what is an appropriate stimulation threshold with respect to risk for neurologic injury. This one was essentially 1,200 patients, 8,500 screws, looking at lower extremity SSEPs. They had 187 screws stimulate less than 8, and that led to outcomes 4.34 times more likely to have clinical symptoms postoperatively. So some evidence of neurologic either injury, pain, motor weakness, etc. They also noted that this correlated with smoking and lower extremity deficits. This was at a specificity up to 90%, and their conclusion was that less than 8 is a good cutoff as far as a load stimulation threshold, and that was consistent with the other literature I saw as well. So if it is less than 8, recommend checking the accuracy on either repeat fluoro or just redirect the screw. You can always remove the screw, palpate with the sounder, and make sure that you're still in the canal without any significant breach. So it's accurate, but is it worth it? Especially with the increased radiation exposure over longer careers. Got to make sure that it's better than what we're currently using. So this traditional posterior approaches involved a lot of muscle morbidity. So this looked at muscle trauma of open versus percutaneous techniques, specifically multifidus muscle atrophy and then trunk extension muscle strength. As a retrospective review, they compared MRI pre and post operatively and looked at the cross-sectional area, which was significantly decreased in the open group, but no difference in the percutaneous group. There's also less blood loss and lower postoperative medication use in the percutaneous group, but no difference in VAS, JOA score, or patient opinion on outcome. These are the MRIs that they used. You can see on the top is the percutaneous group, and then on the bottom is the open group. They compared signal intensity between the multifidus and the psoas muscle. Their key finding is in the bottom right. You can see a little bit of increased multifidus muscle signal, specifically on the left there, on the left side, and that was in the open group. No difference in trunk extension strength. With respect to postoperative recovery, this was a prospective randomized control trial with 3-year follow-up. They found that percutaneous minimally invasive had less blood loss, shorter OR time, and shorter length of stay, as well as less pain. And they actually found better functional recovery at 3 months. It's one of the studies, a lot of the studies didn't necessarily connect it to that time point in terms of functional recovery. It was more of if you have less muscle trauma, is there a theoretical benefit from that? But they were actually able to show better recovery. Paraspinal also had better kyphosis correction with restoration of the vertebral body height, but there was no difference in long-term outcomes. So those were more radiographic findings. They suggested that you can choose either on comfort level or based on postural reduction. So once the patient's positioned well in the OR, if you do need additional correction and you didn't get as much just with positioning alone, then it may be worth doing more paraspinal approaches. This looks at their recovery time. You can see that their quicker recovery at 3 months quickly normalized by 6 months. So that kind of lends credence to the theory of direct muscle trauma being a significant factor. So we have safe, we have shorter recovery, but does it actually work? Does it accomplish our surgical goals? This is a meta-analysis from Global Spine Journal in 2014, looking at 6 studies. Similarly, throughout pretty much all these studies was percutaneous screws had less blood loss, less operative time, but they found no difference in vertebral body height, kyphosis angle, or VAS score. So to them, with less OR time, they concluded that this may provide support for using these techniques in the unstable polytrauma patient. Just with decreased OR time, you're getting less muscle tissue trauma, and that may be a significant factor in that patient population. This is another one looking at the comparison of open versus percutaneous pedicle screws. Again, is it accomplishing the surgical goals that we want, specifically with radiographic outcomes initially? This is a prospective randomized cohort study, 60 patients with neurologic deficits and at least 1-year follow-up for 59 of the 60. They provided instrumentation 2 to 3 levels above or below the fracture site based on surgeon preference. They also used a rigid brace for 12 weeks postoperatively and removed all implants at 1 year, which is a little bit of a debated topic that we'll talk about shortly. It is important to note that their MIS cohort had posterior decompression as well with screws, and they showed superior VAS, JOA, and perioperative data, again indicating less iatrogenic trauma in the MIS group. They also noted more X-ray time, less X-ray time in the open group, more in the percutaneous group. So it works, but how well? Can you get away with less invasive surgery of the less invasive surgery? So meaning, can you kind of decrease your into a short segment fusion? So this is a retrospective review of 46 patients out of Maryland. They looked at a short segment posterior fusion, so 1 level above, 1 level below the injured segment, specifically at correction loss and instrumentation failure. They had an average of 7.5 degrees of correction loss, which was protected by instrumentation of the fractured vertebrae. So you can see in their x-rays there, they do put pedicle screws on bilaterally, if possible, into the fractured vertebrae, which is not always possible, obviously. And they had no relationship shown between load sharing classification, AO classification, or loss of correction and the level of injury. In group 1, 2, and 3, they had either bilateral pedicle screws, unilateral pedicle screws, or no pedicle screws at the fracture level, again, based on surgeon discretion. And then they had a subset group looking at the presence of a crosslink as well as mono versus polyaxial screws. Essentially, they found no difference in the vast majority of those, and no difference in screw type, no difference in the use or not of crosslink devices, as well as no difference in fracture location. And this was one of their examples looking at an L1 burst fracture, again, with the short segment fixation. So just capturing 1 level above, 1 level below. I'm not sure why, based on these images, why they weren't able to get percutaneous screws into the fractured vertebral level, but either way, they didn't use them there. So if you're going to do these, there's a concept that a lot of people describe of an internal brace. So once you have percutaneous or posterior instrumentation that can kind of restore the posterior tension band, provide additional stability of that level, but do you necessarily need to fuse these, especially with bony injuries and intact ligamentous structures, or can you just brace them and allow for the bone to heal, similar to an internal brace or an internal cast? This is a prospective randomized study of 58 patients looking at 30 fusion and 28 non-fusion burst fractures, average follow-up of 41 months, so definitely enough time in order to capture their primary objective. They found no significant difference with loss of kyphosis or low back pain outcomes, which makes sense. You're still doing the same percutaneous screws that we've previously shown are accurate, similarly between percutaneous and open, so you wouldn't expect any difference as far as biomechanical fixation. They did find that their non-fusion group was better, had angular change of 4.8 versus 1 degree on flexion extension lateral views. They had loss correction and decrease, or loss of the previously restored vertebral body height, 3.6 in the non-fused group versus 8.3, and then less intraoperative blood loss and less OR time, which makes sense because it's a shorter procedure. This is just their more specific findings. Is a pretty interesting figure from the paper that I hadn't necessarily come across before. It's describing a Lorderizing screw, which they describe as a screw that is placed a little higher starting point in the fractured vertebral body, or sorry, of the injured level, and that allows it to reduce into more lordosis and restore and eliminate some of the kyphosis from the injury at the time of screw or of rod implantation. They did note that this was typically done on the right in order to save the left side approach for a left anterior decompression if needed, and they did not use screws if both pedicles were injured. So once you do these implants, do you need to take them out? 13 articles, 673 patients, 2022 systematic review and meta-analysis out of Australia. They found a significant 16-degree improvement in sagittal Cobb angle following surgical stabilization. Following removal, that decreased to 9.7 degrees, which was statistically significant at 12 months, and then eventually had 10 degrees loss at final follow-up. If the implants were retained, then they had 10 degrees loss at final follow-up. So it's pretty interesting. They eventually had the same amount of loss with no difference. They also looked at VAS scores, which improved in the removal group more so than in the retention group. Similar results seen with ODI. So planned implant removal results in superior functional outcomes with no significant increase in kyphotic angle correction loss. So I think that's a pretty significant finding. To me, it also makes a lot of sense, which we'll see in this study. I don't think there's really other areas of the body that you would leave implants in, stabilizing a joint that you don't intend to fuse. So this is Jerry and I, iatrogenic pseudoarthrosis, which is my way of saying we meant to do it. So thumbs up from the two of us. This is a study that looked at residual mobility of instrumented and non-fused segments in the thoracolumbar spine fractures. 21 patients, 46-month follow-up, basically looking at how much mobility is recovered following implantation removal. They found 75% with normal or decreased range of motion and 25% without mobility. So at removal with less than 10 months postoperatively, there's 83% normal or decreased mobility compared to greater than 10 months postoperatively. I think typically most people say at least 9 months, usually closer to a year. So I was a little surprised that this 10 months was below that, but may give second thought as far as when we're taking these out in order to save some of the mobility at that level. They also look at disc height and range of motion, which you can see below. And then they did have non-mobile segments, obviously, in about 16% less than 10 months and then 30% greater than 10 months. So these will fuse eventually if you leave it in long enough. Kind of moving away from pedicle screws, other applications of these techniques, you can frequently hear about these techniques being used in kyphoplasty patients. So they looked at 151 compression fractures in 117 patients, looking at kyphoplasty and postoperative outcomes. There's significant improvement in pain scores, ambulation, and prescription pain medication use, which is pretty significant findings considering that's the primary complaint in this patient population. So it's usually elderly patients, low energy trauma, not as high demand or high functioning as some of our younger patients, and they just, I mean, these injuries hurt, as we all know. So really looking for pain control, and then decreasing prescription pain medication can reduce polypharmacy and prevent a lot of additional medical complications. They found these results were maintained over time. So vertebral body height increased at all intervals. At least 90% of patients had a greater than 10% increase in vertebral body height, which is relatively pretty impressive. These outcomes were maintained at 2 years, and the clinical and radiographic effects were both rapid postoperatively and then did not deteriorate. It did note asymptomatic cement extravasation of 11%, which we've talked about in the past, but there were no complications associated with that. They also noted 4.5% rate of additional compression fractures at untreated levels. Other technique applications, lateral corpectomy. This can be used to provide anterior decompression and stabilization, as well as anterior column support with a less morbid approach. This study looked at 52 patients with lateral corpectomies for burst fractures with neurologic deficits and 2-year follow-up. They ranged from T7 to L4, most at the thoracolumbar junction. Obviously, if you're in that area, you have to take consideration of the diaphragm and how that's going to be managed both intraoperatively as well as postoperatively with chest x-rays, chest tubes, etc. They provided supplemental fixation, 75% via anterior lateral plate, 46% via transpedicular plate, 20% combined. That was a little surprising as well. In my experience, most people would do transpedicular plates, pedicle screw supplementation as well. Significant neurologic improvements postoperatively with no patients that had additional deterioration, 13% complication rate, but no secondary surgeries. They used an expandable wide footprint titanium cage in 31% of patients. Their goal was to decrease subsidence risk, which you can get with a smaller footprint. And we'll see on the next slide. Their mini open approach kind of balances large thoracotomies on one end with endoscopic techniques on the other, kind of finds a middle ground between the two. No need for a second surgeon. You can get adequate anterior decompression, like I said, with restoration of the sagittal alignment and anterior column support. The supplemental fixation aids in fusion rate and prevents peri-implant failure. And you can get decreased risk with the less invasive approach. This does have complications similar to other lateral surgeries of thigh numbness, pain, and weakness secondary to psoas dissection. So this is looking at some of their findings, and then on the right you can see the subsidence with the implant kind of subsiding into the end plate, especially superiorly. It's kind of hard to tell caudal if that's where it was, and it's just not a good end plate prep, but cephalad, definitely looks like it's subsiding a little. So lots of benefits, obviously. What are the drawbacks and why not? What's the argument against it? So this is looking at the learning curve that we talked about. Essentially, the definition as used in this paper was the change in frequency of complications in OR time with increasing case number. Their systematic review, those were two kind of key variables that were frequently reported in different studies. They found 5 surgeries were commonly reported, so that's what they used for their analysis: MIS decompression, TLIF, percutaneous screws, ALIF, and cervical procedures, so ACDF, ACDR. 15 articles, almost 1,000 procedures. Their most common decompression complication was durotomy. And then the most common fusion complication was implant malposition, neural injury, and non-union. This kind of gets back, especially with implant malposition, you got to be able to see what you're doing, and you got to take great care with respect to location and anatomy in order to make sure you're doing a good job and a safe job. Overall complication rate was 11%. They found that in general, depending on which specific surgery you were talking about, this decreased around 20 to 30 cases consecutively into the minimally invasive techniques. Inexperience was trended towards longer operative times and significantly increased radiation. It's also important to remember that trauma is not elective. So at the end of the day, you just need to do a good job. And surgery comfort may be more important than normal, meaning more important than an elective case. They also noted that it's possible surgeons self-select for easy cases during the initial training period, which makes sense. You're trying to be safe first and foremost. The other big reason is radiation exposure. So this was an in vitro study looking at the occupational hazard of radiation exposure. I found that essentially the thoracolumbar procedures, especially percutaneous screws, were 10 to 12 times higher radiation dose exposure than non-spinal musculoskeletal procedures, so much more significant. Most of that is from the backscatter, the beam or emitter side, and especially within the lumbar spine due to higher energy required for soft tissue penetration. Lots of things can influence this, which we'll go over on the next couple slides, specifically location. So where are you in the body, the distance to the beam, the patient weight, and the fluoro time used, as well as some of the other fluoro techniques. Prevention of excess radiation exposure primarily is awareness. If you're not aware of the problem, you're not going to track it or fix it. You can utilize lead shields in the room for additional safety. Last picture display, so left to righting images, saving the image on the screen to glance at so you're not repeating images, and then avoiding going live, which is not something I think we frequently do in spine surgery. Pulse images can reduce exposure 20 to 75%, as well as collimation can reduce scatter. Lead gloves can reduce radiation exposure by 33%, but they can be more expensive than normal gloves. So who pays for that? Is it cost effective, or still things that need to be studied? Primarily, maintaining a safe distance from the radiation source is probably the best method of prevention, other than not doing the surgery in the first place. But 3 to 4 feet distance can reduce radiation exposure to negligible level. I think most people typically use 6 feet as kind of the safe zone. And then also increasing the length of the instrument by 5 to 10 centimeters can significantly reduce it as well. So this is on the bottom right, you can kind of see how they did the study, looking at both source and capture side of the radiation exposure. The source side matches the highest image intensifier side. 35 centimeters is approximately 14 inches. So you can see pretty much across the board, regardless of which side you're on, the further you are away, the better. And so at 35 centimeters, you're pretty safe, relatively speaking. And this can also change with level as well. With respect to weight, they found, or they had 6 cadavers in this study. 3 were under 150 pounds and 3 were over 150 pounds. I don't think they necessarily designed it that way, but they found that there was significantly more radiation exposure with the larger cadavers, again, at all time points, all locations. So in conclusion, I think MIS can be a very helpful collection of techniques and approaches in surgical instrumentation. You have to make sure that you're achieving the same surgical goals. It's got the option to minimize damage to the soft tissue and all the benefits that we talked about before. But if you're not accomplishing your surgical goals, then you should probably try another technique. You still have to maintain and respect kind of the lumbar spine surgery in and of itself. So neurologic decompression, adequate stabilization, and deformity correction. And it's important to get adequate intraoperative imaging for both safety and success reasons. Ultimately, the best surgery is safe surgery, so do what you're most comfortable with. That's all I got. Any questions?
I have a question about what you said. It was 35 centimeters, or what was it? 32 centimeters was about 14 inches.
Yeah.
So, I mean, Dr. Bruffy's head is definitely 35 centimeters away from the beam at all times. But it seems like he had some experience with radiation exposure. So, how do we explain that?
Well, I mean, the 35-inch number is not, it's basically a byproduct of this study itself, right? That's just the maximum distance that they looked at. My goal there of 35 centimeters being 14 inches is just to give context of approximately how far you have to stay away. I think I've come across other studies about orthopedic surgeon and cataract exposure, and essentially, I think the average is like 10 years into practice. People start seeing symptoms of cataracts, which is believed to be a radiation exposure sequelae. So I think to be totally safe, you either have to be, behind a lead screen or 6+ feet away. This study said 3 to 4 was adequate. I think 6 is the one that's typically quoted, but ultimately there's still some risk. It's just the amount of radiation. So I guess if his head was closer, it would have happened sooner. I'm not sure.
Well, I mean, he's
Cumulative,
done
guys.
thousands of cases.
Yeah. Yeah, no, it's definitely, I mean, this is a career-long thing. So, I don't think this technology is going anywhere, though some of the navigation-based techniques and robotics techniques have the ability to limit this. They have their problems as well.
If Bruffy had a robot, he wouldn't have needed that cataract surgery.
Yeah. We got to take that one to the hospital and let them know.
Yeah. Thanks, guys. A little late now.
Nice job.
Awesome.
Hey,
Well,
great job,
thank you
Mike.
guys.
Thanks for digging into it and helping us out. There's a lot of nuance to it. And I'll just say what I a lot of times say when we review a lot of studies is just be aware of averages. They don't take into account each individual patient. So helps guide us, but doesn't always dictate exactly what you should do. So, but does dictate, I think, thought process and how to be thoughtful about how we care for these patients and how to decrease their morbidity. So thanks for looking into it.
Yeah, of course.
Thank you, Mike. Appreciate it.
Awesome.
All right, guys.
Have a good day, everybody.
Have a great day.